Hypertension carries a heavy clinical burden. Chronically elevated hydraulic pressure shears endothelial linings, forces the heart into left ventricular hypertrophy, and systematically destroys the delicate renal microvasculature within the kidneys. The primary driver behind this deterioration is the renin-angiotensin-aldosterone system, or ROS. While it maintains fluid balance, chronic overactivation of the ROS pathway acts as an engine for tissue aging and organ fibrosis. Standard blood pressure management often focuses on manipulating monitor metrics. Pleiotropic therapy, however, targets the underlying disease process driving the damage. Telmisartan is an angiotensin receptor blocker, or ARB. Its specific chemical structure grants it secondary properties that separate it from the rest of its drug class, offering direct cellular protection to the heart and kidneys. We will map its precise mechanism of action, analyze its unique pharmacokinetic profile, evaluate the clinical trial evidence, and detail the critical prescribing and dental considerations required to use it safely. Grasping telmisartan's pharmacological profile provides the tools to move beyond symptom suppression toward targeted cellular protection. The cascade begins at the kidney, releasing renin. This interacts with the liver's angiotensinogen. Moving down the flowchart, angiotensin 1 reaches the lungs, where ACE converts it to angiotensin 2. The bottom arrows illustrate its systemic effects: intense vasoconstriction, sodium retention, and target organ fibrosis. ACE inhibitors attempt to solve this by stopping the production of angiotensin 2. However, this causes a buildup of bradykinin in the lungs, leading to a persistent dry cough. Telmisartan takes a different route. It acts as an insurmountable antagonist at the AT1 receptor. It physically occupies the receptor site, blocking angiotensin 2 from binding without interfering with bradykinin breakdown. Blocking this specific receptor yields immediate results. Vascular tone drops, reducing hydraulic resistance. Adrenal glands suppress aldosterone, preventing excess sodium retention. By halting the cascade directly at the tissue level, telmisartan neutralizes a potent pro-aging signaling molecule in the exact organs where it does the most damage. Comparing the pharmacokinetics of common ARBs reveals significant differences. Valsartan clears the system in 6 hours, and losartan in 9. Telmisartan remains active for 24 hours, the longest half-life in its class. That 24-hour window is clinically vital. It provides full circadian coverage, specifically blunting the early morning blood pressure surges heavily linked to ischemic strokes. Furthermore, telmisartan is highly lipophilic, resulting in an immense volume of distribution. While valsartan distributes into about 17 liters of tissue, telmisartan achieves a steady-state volume of up to 500 liters, allowing it to penetrate deeply into target organs. This deep tissue penetration is paired with a second unique mechanism: its role as a partial agonist of the PPAR gamma receptor. The PPAR gamma receptor acts as a metabolic switch within myocardial cells, dictating exactly how the heart utilizes sugar and fat for its energy demands. In patients with insulin resistance, the heart often uses fuel inefficiently. It requires more oxygen for the same workload, creating metabolic exhaust and wearing down the myocardium. Telmisartan's partial agonism improves cellular insulin sensitivity. This restores the heart's ability to switch smoothly between sugar and fat, repairing its metabolic efficiency without causing the weight gain and edema seen with full agonists. The combination of deep tissue penetration, reliable coverage, and metabolic repair makes this compound uniquely suited for cardiovascular protection and off-label longevity protocols. Theoretical mechanisms require clinical proof. The on-target trial served as the definitive test, pitting telmisartan directly against ramipril, a gold standard ACE inhibitor. In over 25,000 high-risk patients, telmisartan provided equivalent protection against cardiovascular death, myocardial infarction, and stroke, but with higher tolerability and fewer side effects. A parallel study, the TRANSCEND trial, proved this efficacy extended to patients who were intolerant to ACE inhibitors, providing them a comparable cardiovascular shield. The most profound finding from these trials was the effect on left ventricular hypertrophy, the dangerous thickening of the heart muscle caused by chronic pressure. Telmisartan drove a 21 to 37% reduction in the risk of left ventricular hypertrophy. This structural reversal occurred even in patients who maintained normal blood pressure. The benefits extend to the renal system. Telmisartan reduces intraglomerular pressure and decreases albuminuria, which slows the progression of diabetic nephropathy. The clinical data confirms the pharmacology. Telmisartan remodels damaged organs and reverses structural cardiovascular decline. The standard adult starting dose is 40 milligrams daily, which can be titrated up to 80 milligrams for severe hypertension. In uncontrolled cases, it is frequently utilized in single pill combinations, such as Twinsta with amlodipine, to achieve up to a 50 millimeter of mercury drop. Common adverse effects include dizziness and first-dose orthostatic hypotension, particularly in patients who are volume depleted. There is a severe clinical warning. All ARBs are absolutely contraindicated in pregnancy due to lethal teratogenic effects on fetal development. Because the drug blocks aldosterone, the kidneys retain potassium. Clinicians must monitor for hyperkalemia, especially in patients with chronic kidney disease. For dental professionals, patients taking maximum doses are prone to orthostatic hypotension. Always raise the dental chair slowly to prevent syncope. This kidney glomerulus highlights a critical drug interaction. NSAIDs constrict the afferent inflow tube. ARBs dilate the efferent outflow tube. Administering both causes the pressure inside the central filter to suddenly drop to near zero. Dental professionals must strictly limit NSAID prescriptions for patients on ARBs. Co-administration can crash the glomerular filtration rate and trigger acute renal failure. Telmisartan is protective, but it requires clinical awareness. It alters exactly how the kidneys manage hydraulic pressure and electrolytes. This clinical matrix outlines 3 patient archetypes for telmisartan: the hypertensive diabetic, the ACE-intolerant patient, and the elderly requiring morning stroke protection. It is the drug of choice for the diabetic patient because it physically protects the renal microvasculature while providing PPAR-gamma metabolic repair. For the ACE-intolerant patient, it eliminates the dry cough while delivering the same cardiovascular protection as gold standard inhibitors. The rapid recall exam pearls. Telmisartan possesses the longest half-life, the highest lipophilicity, and unique partial PPAR-gamma agonism compared to all other ARBs. The absolute contraindications remain pregnancy and bilateral renal artery stenosis. The primary prescribing rule across all disciplines: closely monitor or avoid concurrent NSAID therapy to protect the kidneys. Mastering the RAS pathway and telmisartan's receptor profile allows clinicians to address the underlying metabolic and cardiovascular deterioration rather than managing monitor metrics in isolation.